when it comes back, her feed comes back, we'll let her reintroduce herself. Let's see, let me see. Y'all hang on just a second and we can see if we got our presenter admitted.
We do. This is Jody. Did we get, are y'all seeing the right screen for the
Yes, we can
slides?
see the
Okay,
screen.
great.
Yeah.
Thank you for the patience and thank you, Dr. Olivier. Um, so Paula just re-entered. Paula, are you able to introduce yourself? Not ready yet, but we'll go ahead and move forward. This is the agenda for today. Like Dr. Olivier mentioned, we have a hub team that helps to organize and plan these presentations. This is a tight schedule, so we'll do our best to stick to it. Today, we don't have an identified case presentation, so after Dr. Brown presents the didactic, we'd like to open the floor to any questions that the audience may have about either current cases, about previous discussions, about things that you've seen or reviewed, or just anything that we'd like to discuss as a group. So that's going to be a little different than we've had in our previous sessions, but we're going to go with it and see what kind of discussions we can have. As Dr. Olivier said, we do have our hub team and I am part of it. I am the provider-to-provider consultation line program manager. That is the agency or organization that sponsors these echoes. We provide mental health consultation to providers and professionals that work with families and children. The focus of this Echo series is perinatal mental health, but we have another one that's focused on pediatric mental health, 0 to 21. If you have any direct work with clients or families and patients, you can contact us if you have questions about community resources, referral. If you have a medication or diagnostic question, we can connect you to a psychiatrist that works with a program like Dr. Finelli and Dr. Vincent. But we also have ongoing trainings like these echoes. So in addition to, that's just, these educational sessions are a part of the services that PPCL provides, and the other line of that is the consultation program. So this is the QR code that gets you to our website. There's also our phone number, so you can contact us if you have any questions. But we're going to go ahead and move forward. I'm going to hand it over to Dr. Olivier. Oh, I'm sorry, to Dr. Brown. And Dr. Brown, just let me know when you're ready to promote the slides, and I'll do that for you.
Sure. Thank you. And so today's talk will be about perinatal OCD. Next slide. My disclosures are that I have no disclosures. And it's fine that we are not discussing a case because I brought one of my own. I learn and I teach best through cases. And so this is a composite based off of patients that I commonly see in my practice. So we'll say that you have a 44-year-old G1P1. She's 10 weeks postpartum, no major medical or psychiatric history, and she's being seen in the outpatient setting in great distress because of thoughts of harming her son. She has no desire to do so, no intentions at all, but for a significant amount of time each day, sees herself doing activities like stabbing him with a knife, cutting his legs off, dropping him onto a hard surface, and nothing has ever happened like this before. And she worries about it becoming a reality to the point that she has cleared the nursery of potential objects of harm, and she has her husband and mother-in-law sit in with her while nursing to make sure that the baby is safe. She does think that this is helping distract her from some of these thoughts. And she also reports checking every night, several times each night, to make sure that her son is breathing. She'll look at the monitor, she'll look next to her, and just to be safe, she'll put her hand over the face to hear and feel the breath on her hands. Next slide. She also reports decreased sleep. It's interrupted as would be expected. She's getting about 4 to 5 hours a night, and she tries to nap when the baby naps. We've heard that a lot. She's still pretty fatigued throughout the daytime. She denies feeling particularly depressed, though she did have symptoms that seemed consistent with baby blues earlier in a postpartum period. Appetite's fine, concentration is fine, incredible guilt involving the thoughts although she's able to rationalize and say, I know I'm actually doing a good job as a mother. She has a very strong social support system, and she is currently breastfeeding. Next slide. And as I said, past psychiatric history is unremarkable. She has a mother treated successfully for GAD with Lexapro. Both mother and father with histories of alcohol abuse, both are sober. No family history of suicides, and no family history of mood or anxiety symptoms in response to flux. Next slide. She's not a native to New Orleans. She is well educated. She has worked for many years and intends on being a stay-at-home spouse. A mother lives with her husband of 8 years, who's very supportive. No substance use history at play. Menarche at 13, cycles are regular without premenstrual worsening. They have not returned yet. She's as I said, G1P1 delivered via C-section about 2.5 months ago, sexually active using condoms and is nursing. Next slide. And so if a patient's coming through your doors, you might ponder the following. You might say, what's going on? You might take a look at the thoughts about harming her child and ask, does she actually pose a risk of harm to her child? And you'd wonder what kind of treatment that she might need. And hopefully after today's talk, you'll feel confident walking away with at least having OCD, obsessive compulsive disorder, on the radar. Serious consideration to that diagnosis. Next slide. And so OCD is broken down into obsessions and compulsions. And so we'll spend a little time discussing each. So obsessions are defined as recurrent, persistent thoughts, urges, or impulses that are intrusive in nature and unwanted. Most individuals are going to describe a lot of anxiety or distress associated with the thoughts. If they attempt to ignore or suppress the thoughts, it likely will heighten the anxiety. And as a result, patients may attempt to neutralize them with another thought or an action, i.e. a compulsion. Common intrusive thoughts and obsessions include fear of contamination. So one might describe fear of picking up germs from sitting in a bad chair, shaking hands, touching door handles. They may have fears that tend towards the more aggressive side, fear of driving a car into a tree, running someone over, stabbing a friend. Next slide. And so compulsions are the actions or behaviors that an individual will perform in response to anxiety. They may recognize them as being nonsensical, but they're incredibly difficult to resist. And a lot of times anxiety will not alleviate itself until the behavior is completed. For example, people might describe repeatedly checking appliances, water faucets, the lock on the door before it is okay or it feels right to leave the house. They'll use that phrase a lot, feels right. If somebody has a bad thought, they might neutralize that by silently reciting a good thought to even it out. Next slide. And then OCD is the presence, therefore, of obsessions, compulsions, or both. You actually don't have to have both, but commonly both will occur. By definition, OCD is time-consuming, or it's causing clinically significant distress or impairment in important domains, areas of functioning. And for most of our diagnoses, it cannot be owing to the effects of medication or to another illness. Next slide. OCD is actually very common, a lifetime prevalence of around 2 to 3%. More will report subthreshold symptoms. In adulthood, the prevalence is more common in women compared to men. Average age of onset around 19 and a half years. And patients will usually describe a chronic course. Some will have severe episodes. Others might describe a more waxing and waning of symptoms over time. And patients will often have comorbid anxiety, mood, and tic disorders. Some of the most common themes around OCD include contamination obsessions, and these often get paired with cleaning compulsions, symmetry obsessions that can get paired with repeating, reordering, or counting, fear of harm to self or others. Those intrusive thoughts or obsessions get matched a lot of times with checking compulsions, and sometimes forbidden or taboo thoughts, which can often get matched with a checking compulsion as well. Next slide. In the perinatal period, it's important to recognize that OCD sometimes might present differently. Obsessions very commonly involve harm to the infant and can often be in bizarre ways. Placing the baby in an oven, throwing the baby off a carousel. And the compulsive behaviors often include removing or avoidance of potential objects that are thought to be harmful to the baby, or checking the baby. I even had one patient who was a physician. She knew and envisioned dropping her baby when she was walking down the stairs. And so she would scooch down the stairs in public on her butt with the baby in hand, just so that she would make sure she could guarantee and relieve herself that she wasn't going to harm the baby unintentionally. Patients have insight that this is not common, and as a result, they're often reluctant to discuss intrusive thoughts or compulsive behaviors directly. There's also a very real potential and fear that CPS might get involved if they are forthcoming and they're honest, and new mothers are going to want to avoid that. They may present and couch and discuss it in terms of feeling depressed or feeling anxious. I feel very guilty. I feel very anxious. And so it's really important to normalize and ask very directly, and then provide reassurance if intrusive thoughts are present. Next slide. And in the perinatal period, it's really important for women to know that most will have some form of obsessive thoughts. A lot of parents, especially new parents, will have intrusive thoughts around dropping the baby. Almost every mom that I've talked to has had some thought of dropping the baby, especially early on. The key is that these thoughts are going to be less intense with OCD. They typically are fading within the first 4 weeks postpartum, and they're not impacting level of functioning. There's no impairment in those domains. For women without prior OCD, the birth of their child can be the precipitating event for the onset of symptoms, and that's usually happening within those first couple weeks after delivery. And then important, if you're identifying a mother with OCD, to screen for comorbid postpartum depression. And if you have a mom with postpartum depression, that you're screening her for postpartum OCD as well. 41% of depressed moms often will have some intrusive thoughts around harm coming to baby or of harming baby directly. Next slide. And so other things that you would want to consider carefully and rule out in terms of a differential diagnosis, normal behavior. As we just went over, intrusive thoughts are pretty common in the postpartum period. You'd want to consider postpartum mood disorders, in particular postpartum depression, postpartum mania. You'd consider psychosis with infanticidal thoughts, and OCD would also be on your radar. Next slide. I think when patients often present, especially if they're presenting in an emergency room setting, or if they're not presenting to psychiatry, there can be a lot of concern for the provider to know, I don't want to miss something significant. How do I know that this isn't postpartum psychosis? How do I make sure that if I let this patient go home, there's not going to be risk of harm to the child? And the literature is very helpful and distinct in helping to tease that out. So lower risk thoughts, mothers will often report good insight. The thoughts are scary, they're concerning, they're ego dystonic. They're not considered part of that person's character, that nature. The mother has not acted on the thoughts, does not want to act on them, and often has taken significant steps to protect the baby. On the other hand, higher risk thoughts are often accompanied by a lack of insight. They're ego-syntonic. The mother feels that there's a reason why this seems to be sensible, and they might describe feeling tempted to act on them. Usually this is accompanied by other psychotic phenomenon, delusions, hallucinations, oftentimes related to the baby, i.e. that the baby might be a demon or is possessed or is at risk of harm. If there's a history of violence, that would increase those thoughts to be potentially higher risk. If there's a history of labile mood and or impulsive behavior, more consistent with a past mania, you again might be worried about psychosis. Next slide. All right, so if we take all of that information and we go back to our patient, we'd rule out normal behavior, the amount of time spent in her obsessive ruminative process and the compulsive behaviors is obsessive, and there's clear impairment in her domain of parenting. She's impaired functionally. Next. We can rule out a postpartum mood disorder because she's not really reporting feeling particularly depressed or anhedonic. There's no evidence of visible mania, hypomania. Next. We can rule out postpartum psychosis. We're not worried about infanticidal thoughts because there's no psychotic phenomena accompanying, and the thoughts are clearly described as ego-dystonic. And so that really leads you with a diagnosis of OCD. Next slide. So I like the why box when you're trying to gather more information around OCD. If you suspect the diagnosis, always can be helpful to administer. But sometimes even if you've made the diagnosis, this can still be a really valuable tool. The Y box is actually a super long document that can take quite a bit of time to administer in the office setting and may not always be practical. I like the Y box symptom checklist because it can be administered in office. Sometimes I'll assign it, even if I've clinched the diagnosis, for homework for the patient. And it takes about maybe 5, maybe 10 minutes at most. And it allows them to review common intrusive thoughts or obsessions, common compulsions, and identify what might have been present, not only now, but what might have actually been an active symptom in the past that they just simply disregarded. A lot of times patients will come and they've had symptoms throughout their lives and they just really never knew. They wrote it off. And having a clear understanding of what an obsession might entail, what a compulsion might entail, I think can be really valuable for them for realizing that this is not necessarily an uncommon thing, that it's common, it presents in a variety of different flavors. And so it can be a really valuable educational tool for patients. Next slide. So with this patient, her Y-box symptom checklist revealed things that she just said. She's like, I thought those were quirks. My husband and I just wrote it off. But when you nail her down, she admitted that she doesn't cook because she's worried about unintentionally causing food poisoning. And she had a period of 2 years in elementary school where she refused to eat red foods and they just didn't feel right. So she just never did. And her parents just kind of said, oh, well, they could accommodate it. It was easily shrugged off as being just a little unusual. She also reported some checking of locks at home at nighttime that husband kind of felt was maybe a little bit excessive and obsessive. So you've made the diagnosis, you've shared your clinical impressions. She wants to know about treatment options. Next slide, please. So keeping in mind that she's breastfeeding, you would discuss a variety of options in terms of medications. SRIs are gold standard. Typically have a very favorable profile with breastfeeding. This patient has a first-degree relative, her mother, that has done well on Lexapro. So if she was amenable, most likely that would be the medication trial I'd pick first. I think it's important with OCD that providers that aren't savvy or are not familiar treating it recognize that you might require higher doses than typically required for simple depression alone. And what is not uncommon is patients will be started on an SSRI or an SNRI, not titrated up high enough, get partial remission, and then the med trial is considered a failure and they're switched. And so they might have seen you and they're on their third or fourth antidepressant, all at sort of substandard doses for OCD. So you have to stick with it. And it sometimes might push you outside of your comfort zone, but as long as they're tolerating the medication, I would urge you to consider pushing to the max or even a little bit beyond if needed to reach full remission. Tricyclic antidepressants, they're oldies but goodies. Usually they're not our first line simply because of having a more narrow therapeutic window and riskier side effect profile. But certainly for a patient that has maybe comorbid pain conditions, is already on it for migraines or chronic pain or sleep, it might be worth optimizing further. Benzodiazepines can sometimes be used in the short term appropriately for OCD. Certainly, it can give acute relief while tolerating an SRI if there's any agitation as a side effect when you're starting off. You'd want to be wary, especially with patients that have significant symptoms for OCD, not to use it as a long-term strategy because the potential for dependence and tolerance is it's pretty readily. And then in terms of severe refractory cases, or if you have a patient that may, let's say, maybe has bipolar disorder as a comorbid condition where you would not necessarily be reaching for an SRI, antipsychotics do have decent literature around their effectiveness for OCD as well. Next slide, please. It's also really important to think about non-pharmacological approaches as well. So for a lot of patients, medications may not be part of their desired treatment plan, and they may be more interested in psychotherapy. And so some common tools that can be helpful when thinking about how to manage patients in that domain, I think psychoeducation is really, really, really important. It can do a world of good for patients. A lot of times these women really feel isolated. They feel like they're losing their minds. They feel a lot of shame and guilt. And helping them to understand what a symptom is and how common the disease is can really be powerful in alleviating a lot of symptoms without having to do much more. I've had patients certainly that have come to my office that have not desired medication. They just wanted reassurance. And once they realized what was going on, it became easier for them to use their own skills to keep their symptoms in check. I think it can be really important for a savvy therapist to not feel afraid of challenging beliefs about intrusive thoughts. I think it can be really helpful in certain cases to confront feared thoughts and situations with practiced exposures in this clinical setting. And I think it's also really important to help them change unhealthy coping strategies that are contributing to and reinforcing that anxiety. So in this patient's case, her mother-in-law and her husband are sitting in with her to reassure her that she can nurse the baby, which basically is a way of reinforcing that anxiety. The only reason she was able to keep her baby safe is because there was another individual in the room, and therefore, guess what? She needs another individual in the room so that she can continue to keep the baby safe. And family members, educating them is going to be really, really important too, because any loving spouse, any loving parent is going to hear potential thoughts of harm, and they're going to want to keep that baby safe as well. It's important for them to recognize that they are reinforcing some of that cognitive distortion cycle that's happening. And so one of the early interventions that I would do with a couple like this is to have the baby, have mother-in-law start to space out and take time away. She can nurse on her own. That will help her build up her confidence. That will help her really identify and connect with the intrusive thought as an intrusive thought. Thoughts do not equal actions, and that would be a good place to start as well. Next slide. I think that's it for me. Yeah, I think I have just room for questions if there's time allotted.
We have